Right now, you'll see Dr. Wolin has just appeared on screen. Now, Dr. Wolin is an internationally renowned authority on net tumors. Uh, he's currently the director of the Center for Carcinoid and Neuroendocrine Tumors, professor of medicine, hematology, and medical oncology. Uh, and he's been pioneering the treatments of NETs for a long time. Is that right, Dr. Wolin?
I think so.
Yes, yes, that is true. So, welcome, Dr. Wolin. I'm done speaking, and you have the floor.
Okay, thank you. It's my pleasure to be able to speak with you today and share a lot of exciting new things happening in the world of neuroendocrine cancer. Um, I'm just going to give a few introductions just to understand the basics of what we're talking about so we'll all be on the same page. And then when I talk about specific treatments for specific conditions, it'll make a little bit more sense. Neuroendocrine tumors, unlike other kinds of cancer, are classified according to where the tumor would have started if you were an embryo. The picture on the right is an embryo, and the picture on the left is what a normal body looks like. And you could see that tumors are named by whether the cells would have originated in the embryo's foregut, midgut, or hindgut. And all the neuroendocrine tumors come from those areas. They have different treatments, different responses to chemotherapy and biologics. And it's important to remember that. So we think about foregut, thymus, esophagus, lungs, stomach, duodenum. Midgut are mostly small intestine and various parts, as well as appendix and um, part of the colon. Hindgut is the rectal area. And pancreatic neuroendocrine tumors are sort of a group by themselves, so that they're basically foregut also. Okay, the classification of neuroendocrine tumors is a little bit complicated, but just think of it in two major groups. There's a well-differentiated group and a poorly differentiated group. Differentiation refers to how nasty the cancers are, how fast they grow, and how aggressive they are. Within well-differentiated, there are three groups known as grade 1, grade 2, and grade 3. As you go up in grade, the tumors become a little bit more aggressive, and the grade is figured out in the pathology department based on how many cells are dividing. The rate of cell division, which can be calculated by something called Ki67 or MIB1. It can also be calculated by counting mitoses, and usually both things are done. And the high grade tumors, we're not going to be talking about as much today in this particular session, but there will be a session on high grade tumors later on. All I would say right now is that the well differentiated grade 3, even though they're high grade, are treated very much like grade 1 and grade 2, and they're not as nasty as poorly differentiated grade 3. The other thing I wanted to tell you is that there's been an explosion of new treatments that have made all the difference in quality of life and survival in people with neuroendocrine cancer. And all of this has happened basically since 1911, just in the last 9 years. These are randomized phase 3 trials that have all led to FDA approval of new treatments. And these are ones that are actually approved. There are a lot more that are still being investigated. And it's just amazing what has happened in the world of treating neuroendocrine cancer. Okay, what I'm going to talk about now is various types of treatments that we have for neuroendocrine cancers and try to make sense out of the large group of things that we have to use for therapy. The first molecular target on neuroendocrine cells that's important. I don't know why the slide keeps changing by itself. But the first molecular target on neuroendocrine cells that we have to think about is the so-called somatostatin receptor. Somatostatin receptors are found on the membrane of most neuroendocrine cells. Most carcinoid cells have this somatostatin receptor in their membrane. And when you have a somatostatin receptor, the cell can interact with somatostatin, which is a natural turn-off hormone. It turns off hormone production. It turns off cell growth. It turns off cancer that is made of neuroendocrine cells. but it can only happen if you have a somatostatin receptor and somatostatin interacts with the receptor. What we do in actual practice is we use something called somatostatin analogues. Somatostatin analogues are like somatostatin, except they last much longer in the body. So octreotide or sandostatin, lanreotide or somatulene, those are called somatostatin analogues. And they're formulations of those drugs that last for a very long time. One injection could last for 4 weeks. And that's much more efficient than using somatostatin, the natural form that lasts only 2 or 3 minutes. So that's why we use somatostatin analogues in treatment. The first really important study that put somatostatin analog therapy on the map is known as Clarinet. Clarinet coming from this title, and you really need a little stretch of your imagination to spell clarinet from placebo-controlled study of lanreotide anti-proliferative response in patients with enteropancreatic neuroendocrine tumors. But since nobody could say that, we just call this clarinet. Clarinet is a randomized trial of lanreotide versus no lanreotide versus placebo, actually. And that was done at a time when there was no treatment for carcinoid tumors. So it was felt to be an ethical study to have a randomization with a placebo. And everybody who got placebo would automatically be offered lanreotide if the cancer were to grow. So lanreotide was given to everybody, but it was done in this fashion to determine the effectiveness. There was a study earlier with octreotide, but it didn't reach statistical significance. And to this day, as an anti-cancer treatment to stop cancers from growing, we have lanreotide as the approved drug based on the remarkable results of this trial. Okay, what happened was from Clarinet is that patients who, this is the long-term follow-up from Clarinet, where we know how long the drugs actually work. In people with intestinal carcinoids, the average time that cancer was stopped in its tracks was 61.5 months. Now, 61.5 months is over 5 years, and that's an average. Some people, it will stop the cancer from growing for 10 or 15 years. Other people, it stops it for 2 months. But if you average it all together, you get 5 years. You can see this is a remarkably good treatment. And actually, there's no treatment that's ever been discovered where progression-free survival, so-called, the length of time cancer is stopped, is over 5 years. In pancreatic neuroendocrine tumors and other neuroendocrine tumors, it's a little bit shorter. It's about 38.5 months. But still, these are averages, and some people can go for many years. But this is lanreotide. Octreotide does a very similar thing, but the data is more compelling when in the lanreotide trial. Now, the other thing that we can do with those somatostatin receptors that I just talked about is we could use the somatostatin receptors as a molecular target for somatostatin analogues sticking to those receptors and delivering a radioactive payload. This has become really, really important and exciting. The thing that says target is the somatostatin receptor. The thing that says ligand is the somatostatin analog that's going to stick to the somatostatin receptor, and that is attached to a radioactive isotope. Okay, in the case of making a diagnosis, a so-called reporting unit, we've been using gallium-68, and now we have also copper-64 as reporting units. In other words, when the ligand sticks to the target, when the somatostatin analog sticks, the isotope that's attached shoots out rays to make a scan, a PET scan, and you get beautiful pictures of where the neuroendocrine tumor is. If the scan is positive and you have a positive result on your gallium dotatate PET, it means you're likely to respond to octreotide or lanreotide therapy. And also you're likely to respond to the radioactive kind with lutetium-177 delivered, attached to a somatostatin analog, which we call Prrt, and we'll be talking about also. So this is, again, working on that same somatostatin receptor that we talked about earlier. The randomized trial that was done with a somatostatin analog to prove the effectiveness of using a somatostatin analog we call NETTER-1. This was a randomized trial where half of the people whose cancer grew on octreotide LAR 30 milligrams every 4 weeks, half of the people who had progression of cancer on octreotide got the radioactive stuff, which is called lutetium-177 dotatate, every 8 weeks for 4 treatments. The other group got a double dose of regular octreotide LAR. So instead of 30 milligrams, they got 60 milligrams. And the question is the radioactive kind better than a double dose of regular octreotide LAR? And what happened is the little green line on top is the survival of people, the progression-free survival, living with no recurrence in people who got the radioactive octreotide, dramatically better than the people who got double dose of regular octreotide. On the basis of this study, which we published in New England Journal, and which the FDA then reviewed, octreotide in the radioactive form, we call this lutetium-177 dotatate, was approved by the FDA for Prrt, peptide receptor radiotherapy, and it's now become a standard which is being used all around the world for treating people whose cancer progresses on normal therapy. The response rate, which means major shrinkage of cancer, happened only in about 19%. So about 1 person out of 5 has a major shrink. However, almost everybody has either a smaller degree of shrinkage or stability. And it's only a very rare person where cancer will progress. Okay. The side effects of lutetium-177 are generally not serious. There was a problem in the initial trial with nausea and vomiting, but that was due to amino acids used to protect the kidneys. And we now have a better amino acid mix that doesn't cause nausea and vomiting. And people usually tolerate it with very minimal nausea, if any. Occasionally, somebody's blood counts will temporarily get low. It usually doesn't cause any permanent problems with kidney function, which was one of the fears. With all PRRT therapy, there's a very small risk. It's clearly not more than a few percent, but there's a long-term slight risk of developing leukemia or pre-leukemic changes, which is why right now it's not routinely being used as the first-line treatment to treat cancer, but it's very rare that those serious diseases happen. Those are very, very rare. We're talking only about 2 or 3% of people, but nevertheless, it is a theoretical risk. Now, PRRT not only stops cancer from growing and often shrinks it, but it also improves quality of life. This is a paper we published just 2 years ago on quality of life in people who had treatment with lutetium-177 dotatate on the NETTER-1 trial. It improves diarrhea, it improves flushing, it improves pain, it improves energy, and people do really, really well. It improves their general state of health when patient-assessed health score. It improves their ability to function during the day. So these are all signs of remarkable help from having PRRT. So the question comes up, who should be treated with PRRT? So the approved use is for metastatic neuroendocrine tumor of gastrointestinal tract or pancreas. Tumors should be well differentiated rather than poorly differentiated, although which can include potentially G1, G2, and G3, grade 1, 2, 3. The tumor should be progressive on imaging. The target lesions that we see should, on the octreotide scan, on the gallium-68 dotatate PET or the copper-64 PET, or on the older octreotide scan, it should be positive. Creatinine should be good. In other words, kidney function should be good, and people should be strong enough to tolerate this kind of therapy. There's a new type of blood test, which is now available as a biomarker called the NET test, composed of 51 gene transcripts. This is based on genomic changes in the cells. That is looking very promising. There's also something called PTQ, predictive quotient for response to Prrt, which is looking very, very promising. And we are now starting to use those kind of things in clinical practice with, I think, added benefit. This is a example of a patient who had a gallium dotatate PET cat. This is the CAT scan right here. You could see maybe one tumor on the gallium dotatate, which is the lower level pictures here. You could see two big tumors. After one cycle of Prrt, you could see the CAT scan doesn't show anything, but the gallium dotatate is so sensitive, you see two tumors there. And after 2 cycles, everything is in a remission. This patient stopped after 2 cycles instead of going for all 4 cycles. And what happened a year later, the first time that recurred showed up on the gallium scan before the CAT scan. It's a very, very sensitive test. Okay, and it's changed management in about 60% of patients. There's a new imaging that's similar to gallium-68, and we're going to be seeing more and more of, which is called copper-64 dotatate. It gives pictures that are very much like the pictures that we see with gallium dotatate. It does the same thing. It tells you about the somatostatin receptors, but it has a long half-life, making it easier for patients to be scheduled since the isotope doesn't decay so rapidly. It has slightly higher resolution for seeing more tiny tumors since the positrons that shoot out don't go quite as far. And it shows more tumors actually than the gallium-68 dotatate PET, although it's never been shown to change management. In other words, you would be able to come to the same conclusions and do the same thing using either one of these modalities. And this is an example of somebody who had both a gallium dotatate and a copper-64 imaging. The lower one is copper-64, and you can see down in the pelvis, there are a few tumors that show up more clearly on the copper-64. So I think we have to keep our eyes open on that. It's going to be an important test. We're now looking at other molecular targets, including a high potency form of MIBG. This is a type of Prrt for people who don't have any somatostatin receptors, which is currently a very big problem, and this will allow people to be treated also. That's called Azedra. The next molecular target I was going to talk about, and I'm going rather quickly because I know there are going to be other speakers and we want to get time for everybody, but something called mTOR inhibitors turned out to be very powerful. A drug called everolimus is able to stop cancer from growing and control cancer 11.4 months compared to placebo 5.4 months. That's been approved for pancreatic neuroendocrine tumors and based on radiant-4, approved for lung neuroendocrine tumors and approved for gastrointestinal neuroendocrine tumors. So for all kinds of neuroendocrine tumors, everolimus is another good treatment option. We also have anti-angiogenic drugs that work on the blood vessels. We have sunitinib for pancreatic neuroendocrine tumors. We have a very exciting clinical trial of cabozantinib, which is going on right now, which is a next generation kind of anti-angiogenic that also works on other growth pathways inside of cancer cells, and we're seeing amazing results with that. And we have a randomized trial going. Chemotherapy with oral pills of a very well-tolerated kind of chemotherapy called capecitabine and temozolomide is commonly used now for pancreatic neuroendocrine tumors and sometimes lung neuroendocrine tumors. This is something which is very nice. There was a randomized trial that was just finished comparing temozolomide versus temozolomide plus capecitabine, also known as CAPE-TEM. And the response rate with the combination is 33% of patients have a major tumor shrinkage, and almost all the patients have cancer control, which can often last for a long time. We make decisions about which of these things to do when. This is a list of the options that are out there, which we've been speaking about, we make decisions based on whether the cancer is localized or metastatic. If it's localized, you can take it out surgically or treat it with something directed at the tumor itself. If it's metastatic, we have to distinguish between liver metastases that can be treated by embolization, can be treated by resection, can be treated by ablation, or whether it's widely metastatic disease where we need to treat something, treat the whole body using something like Prrt or a chemotherapy or a targeted biologic. It makes a difference whether the cancer is well differentiated or poorly differentiated. Very important, you have to use your head a little bit. That's what pace of growth means. It means if you have a diagnosis of a well differentiated neuroendocrine tumor that's low grade, and 3 months later you get another CAT scan or an MRI scan and the tumor is much bigger, we know it's not a slow growing tumor. It was just a problem in the little needle poke that didn't get the rapidly dividing part of the tumor. And you have to either get another biopsy or treat the patient more aggressively or do something, but you don't want to just watch the cancer get bigger and bigger and bigger because your biopsy says it shouldn't grow very much. Pancreas versus non-pancreas is important because pancreas responds better to almost every kind of treatment. We have to distinguish if the cancer is functional or non-functional. If you're making hormones and you have carcinoid syndrome or other hormone secretion syndromes, there are many, many syndromes, versus non-functional. If it's functional, you have to treat the syndrome, treat the symptoms, and make the patient comfortable, as well as preventing serious complications like carcinoid heart disease. So that makes treatment particularly urgent. And if you have tumor bulk, which is so big that it's causing compression of vital organs in the body or different structures, that's a tumor that has to be treated much more aggressively than if tumors are little tiny ones that aren't causing symptoms. So always have to balance the outcome versus toxicity. And we have to always figure what is the goal of what we're doing. Are we trying to stabilize disease or shrink it? And what is the risk of adverse reactions? When people are being treated at our institution, we have a multidisciplinary tumor board that meets every single week. We discuss all our patients with treatment issues that need to be discussed, or all the new patients, and talk about what to do and how to do it. And we have every specialist that's involved in all of these different treatments to discuss and debate what to do, because there's no easy cookbook formula for what you do in a particular patient with a particular situation. And we want to clearly have personalized medicine based on what is possible. And other factors influencing treatment decisions sometimes even include genomic profiling and other ancillary information that might predict what patients will respond to. Just to wrap things up quickly, carcinoid syndrome has become something which we could really make a big impact in, and it's important to recognize and treat. Diarrhea of carcinoid syndrome is a watery diarrhea, which is something that doesn't just happen when you eat. It could happen all the time. It could happen all day, all night. Even if you're not drinking water, you could just have watery diarrhea until you're dehydrated. The flushing are attacks of redness without sweating. It's associated with burning and warmth. It's typically on the face and the neck, but can extend to other parts of the body. And you have to distinguish it from other causes of red skin and from the causes of flushing that are, for example, allergic reactions or hot flashes or other conditions. Carcinoid heart disease, we're going to hear a talk on this afternoon, but that's clearly a very terrible complication of carcinoid syndrome. We try to prevent and aggressively treat if it happens. When people have carcinoid syndrome, they also can get a lot of scar tissue forming in the abdomen. It's called fibrosis. You can get vitamin deficiency. You can have a niacin deficiency caused by so much serotonin being used up that you don't have the necessary niacin to produce niacin production from tryptophan, and you can get actually pellagra, which is a serious vitamin deficiency disease. You could also get permanent flushing. If you keep flushing too much, you can get rosacea. So for all of these reasons, we try very hard to keep carcinoid syndrome under control. We can treat carcinoid syndrome with somatostatin analogues, octreotide LAR, and octreotide immediate release. There's a new way of delivering immediate release octreotide called Benfesia pen, which is a pre-filled syringe with octreotide immediate release with an incredibly tiny needle, 31 gauge needle that's just 5 millimeters long. It's really, really, really tiny. It's compact, it's portable, and it can be kept unrefrigerated for 28 days once the pen is started. So unlike other formulations, it makes it very, very user-friendly. And you digitally dial the dose of 50, 150, or 200 micrograms. You just dial whatever you like, or rather what the doctor would prescribe, and you could give it very easily. Going the wrong direction. Okay, lanreotide is excellent also for treating carcinoid syndrome, and based on the so-called ELECT trial, has now been approved, so we can use octreotide or lanreotide, and we have some other things. The most important one I want to mention is called telotrestat. Telotrestat stops the production of serotonin. It blocks an important enzyme that's necessary for production of serotonin, and it reduces diarrhea. It reduces the level of serotonin in the blood and 5-HIA dramatically. So when people have symptoms of diarrhea and that persist despite the somatostatin analog, octreotide or lanreotide, the thing to do now is to add telotrestat. And remember, I said PRRT improves symptoms. One of the symptoms that improves is the diarrhea of carcinoid syndrome. So if somebody has a problem with diarrhea that's difficult to control and they have PRRT, it usually gets better. Be aware that there's something called carcinoid crisis, which is a massive release of serotonin and other chemicals from the neuroendocrine cancer. And one of the most common triggers of this is anesthesia. Epinephrine could also do it, which means caution the dentist not to use epinephrine mixed in with the local anesthetic. And we have to do everything possible to prevent this with lots of somatostatin analogues. I've been using intravenous octreotide, even though that's not necessarily something that everybody is doing everywhere. I think it's a good thing. And you can titrate the dose and you can get all you need, but the anesthesiologist has to be very familiar with this technique. So you don't want to get carcinoid crisis. I whipped through a lot of information. It's been a great pleasure talking to you. And soon we'll have a question and answer time. And if anybody has questions, I'm happy to deal with them. So thank you very much, and look forward to speaking with you later. Bye-bye.